Nursing Care of Cognitive Disorders. Module 1, Delirium, Recognition and Nursing Priorities. Delirium is one of the most important cognitive emergencies you will see in practice. If an older adult suddenly becomes confused, agitated, or disoriented, do not assume dementia. Do not assume normal aging. Think delirium first. Delirium is common. It affects millions of older adults each year, increases hospital costs dramatically, and is associated with higher mortality. But here's the key. It is often reversible if we catch it early, and nurses are usually the first to notice something is off. Early recognition saves lives. Delirium is an acute disturbance in attention, awareness, and cognition. It develops over hours to days, not months, and it fluctuates. This is not a primary psychiatric disorder. It is a direct physiological response to something else happening in the body. Common causes you must think about: infection, especially UTIs or pneumonia, electrolyte imbalance, hypoxia, medication toxicity, polypharmacy, substance withdrawal, dehydration, post-operative states, pain, urinary retention, or constipation. Delirium is a medical emergency until proven otherwise. For NCLEX, you must understand both the DSM-5 criteria and the CAM tool. The 4 CAM features: acute onset and fluctuating course, inattention, disorganized thinking, and altered level of consciousness. To diagnose delirium using CAM, you need features 1 and 2 plus either 3 or 4. The biggest differentiator between delirium and dementia: altered level of consciousness. If the patient is lethargic, hyperalert, or fluctuating in alertness, that's delirium. Always ask, when did this start? What is this patient's baseline? Missing baseline information is one of the main reasons delirium gets missed. There are 3 motor subtypes: hyperactive delirium, agitation, restlessness, hallucinations, easier to recognize. Hypoactive delirium, quiet, withdrawn, sleepy, less responsive. This is the most common in older adults and the most frequently missed. Mixed delirium fluctuates between both. Hypoactive delirium has higher mortality because it goes undetected. If someone becomes suddenly quiet and withdrawn overnight, that is not just tired. Your job is not to document confusion. Your job is to find the cause. Assess baseline cognition, recent infections, medication changes, pain, hydration, oxygenation, labs, surgical history, urinary retention, constipation, substance use. Polypharmacy is a major contributor. Benzodiazepines and anticholinergics are especially high risk. Use validated tools: CAM, 3D CAM, 4AT, CAM, ICU. Screening works. It improves detection. Nonpharmacologic interventions are first line. They reduce delirium by nearly 50% and reduce falls significantly. Interventions include frequent reorientation, clocks and calendars, family presence, early mobility, avoiding restraints, protecting sleep-wake cycles, hydration and nutrition, ensuring hearing aids and glasses are used, pain control, and minimizing psychoactive medications. Constant observation, or sitters, are indicated for patients with delirium when there is a significant safety risk, particularly when patients demonstrate disorientation, inappropriate behavior, fall risk, or agitation that cannot be managed through other non-pharmacologic interventions alone. Sedating a patient without treating the cause can worsen outcomes. Our goal is to find and treat the underlying problem while maintaining patient safety. NCLEX loves this comparison. Delirium, sudden fluctuating, altered consciousness, often reversible. Dementia, gradual progressive clear consciousness until late, typically irreversible. Delirium can occur on top of dementia. Patients with dementia are at higher risk for superimposed delirium. Delirium is not always temporary. It increases mortality risk, risk of institutionalization, risk of developing dementia, functional decline, and hospital readmissions. Delirium accelerates cognitive decline. This is why early recognition matters. As nurses, we must recognize delirium early, assess thoroughly, use validated tools, implement multi-component non-pharmacologic interventions, avoid restraints and unnecessary sedation, communicate changes immediately. If cognition changes suddenly, treat it as urgent. Delirium is common, under-recognized, and dangerous, but it is often preventable, and that's where nursing makes the difference.